know when you're live.
We are live now, doctor.
Okay, so very good evening, everybody. On behalf of Team YOSI, I, Dr. Nupur Goyal, welcome you all for this wonderful event that we have planned today. We have this oculoplasty where young ophthalmologists will be presenting oculoplasty videos, and we have a very eminent panel of judges. And this is being organized by the Oculoplasty Focus Group. So before we actually dive into the video competition, just let us have a brief introduction of the team Young Ophthalmologist Society of India. As the president, we have Dr. Divakan Misra, Dr. Sonal Kalia as the immediate past president, Dr. Karan Bhatia as the vice president, Dr. Nilesh Kumar as the secretary, Dr. Aditya Sethi as a treasurer, and Dr. Prasanna V. Ramesh as a joint secretary. And they're joined by a very dynamic pan-India executive team, as you can see. So over the past years, YOSI has branched out, has had, this young budding society has had many presidential working groups to it. So one of them is the YOSI Oculoplasty Focus Group. So before we actually move on, I would invite our YOSI president, Dr. Divakan Misra, to say a few words on these presidential working groups and the focus group. And also, this is the first activity from the Oculoplasty Focus Group. Over to you, Dr. Divakan.
Thank you so much, Dr. Nupur, and the whole Oculoplasty Focus Group team led by Dr. Puneet himself, Dr. Rituja, Dr. Nupur, and Ayushi. So we thought we had a combined kind of we had a combined group where we did some anterior segment activities, but we wanted to bifurcate these things and so that each group can be given equal importance and focus. So that's how we came up with these group, and we are very happy and excited how well these groups have shaped up, and even Oculoplasty group is doing such nice work. So look forward to these webinars and these focused activities. And best of luck to all the participants, and big thanks to all the judges who have taken out time to judge the competition. Thank you, Dr. Nupur. Over to you.
Thank you, Dr. Devakant, for those encouraging words. And let's now move on to the further things. So as the team lead of Oculoplasty Focus Group, we have Dr. Puneet Jain, who's currently consultant in charge of the ophthalmic plastic surgery and ocular oncology services at Sharpsight Eye Group of Hospitals, India. He was the ex-additional director of ophthalmic plastic surgery and ocular oncology at IQ Super Specialty Eye Hospital, and also an ex-consultant at Center for Sight. So he's done his MD in ophthalmology from RPC AIMS and long-term fellowship from Center for Sight Hyderabad under Dr. Santosh Vanawar. He was also fellow of the Ocular Oncology and Ophthalmic Radiation Therapy at the New York Eye Cancer Center. He's had many publications and presentations to his credit. He's also the section editor at the Haryana Journal of Ophthalmology, and he's won a lot of travel grants, and he's also active presenter at various forums. So Dr. Puneet, over to you to say a few words about the Oculoplasty Focus Group and also introduce the Oculoplasty Focus Group. Over to you, Dr. Puneet.
Hi, very good evening to everyone, and thank you for almost feeding out my entire team. That's my entire team. Anyway, so I'm glad that we were able to build on the idea that was started by GC.
Puneet, your voice is a little soft. If you can just come near speak a little louder. Yes.
Is it better now?
Yeah, it's better. Yes. Yeah.
So building on to the idea with which the GC started of the presidential focus groups, the aim of the Oculoplasty, YOSI Oculoplasty focus group is to build a niche and develop the specialty, and also build a bond, a mentor-mentee bond between the young ophthalmologists. It is very difficult to find space for four specialties when the bread and butter of ophthalmology prevails. In most of the conferences, in most of the webinars. So that was the aim, to have this focused niche group where, all the interested postgraduate students, fellows, and us learn together and develop these mentor-mentee bonds and kind of grow together till we are officially young ophthalmologists. I am glad to have a super active team. I have been on the background, and all this is being orchestrated by Dr. Nupur, Dr. Rituja, and Dr. Ayushi. Briefly, let me know about them. Starting with Dr. Rituja. Dr. Rituja Thomas is the consultant in orbit and oculoplasty surgeon at Vision Eye Centers in New Delhi. She also freelances in Delhi NCR. She is She did her DNBN fellowship in the super specialization in Bangalore. She has had several peer-reviewed publications, book chapters to her name, and is an active presenter both at national and international conferences in various capacities. She also won numerous awards as Best Paper, Best Video, and Team-Based. She is a member of Super Club Specialty Societies as well as on the editorial board of the Oz Times and also DJO. Very happy to have Rituja on board with this, and she's super active. Next, another pocket rocket I would call Dr. Ayushi. She currently is practicing as a consultant in oculoplasty, orbit oncology, and facial aesthetics at Nanda Deep Eye Hospital and PG Teaching Institute in Maharashtra. She has done a long-term fellowship in the super specialty from Melvi Prasad, Hyderabad, where she also served as a chief clinical research fellow. He has been a clinical researcher and has completed the Harvard Medical School research training program in 23-24. She has 30 plus indexed publications in high-end journals, including Survey of Ophthalmology, Orbit, Ophthalmology, Retina. She also has 2 book chapters and a lot of presentations to her name. She's also a awardee, a regular awardee. The latest one being best case at ISO 2024, which concluded in Goa. She's also won travel grants and is also an active executive of YOSI. Last but not the least, the most active member and most, I should say, valuable member of our group, if I would take the liberties, Dr. Nupur Goyal. She has done a long-term fellowship in oculoplasty and ocular oncology at Melvi Prasad, Hyderabad. She's currently working as a consultant in anterior segment oculoplasty at Eye Care Eye Hospital and PT Institute, Noida. She has keen interest in academics and teaching, which most of us know, and she's an active UC member. She holds the position of executive member for this tenure from the last tenure, that is 2022 to 24. She is the Noida Ophthalmic Society Times editor. She is the team leader for YOSI Socioculture Group as well as YOSI IROC Group. And she also happens to be the managing editor of the successful Yo Times. So I'm glad to have such a team where they do most of the work. I am the laziest fellow in this team, and I am super happy that you were able to orchestrate this and start this series. And I wish the team and everybody all the best for a lot of such webinars and events from our focus group. Thank you so much.
Thank you, Dr. Puneet, for introducing the team and those kind words of encouragement. We're also joined by Rituja, one of the core members of the Oculoplasty Focus Group. A quick comment from you, Rituja, on the Oculoplasty Focus Group.
So it's been a pleasure, of course, working with Puneet, Nupur, and Ayushi. And we are actually trying to come up with various things which can involve a lot of the postgraduates, fellows, residents in these things so that they sort of get exposed to the entire network of oculoplastic surgeons across the country, because we have so many and all of them are so talented and there's so much to learn from each one of them. So after this, at the end, Ayushi will be introducing the case presentations as well. That will be the next thing for the oculoplasty focus group. But for now, thank you to Nupur for organizing this so well. And I think all of you will have a good time, even for the judges to judge these videos.
Thank you, Dr. Puneet, Dr. Rituja. Ayushi will join us in a while. It's always a pleasure, working with you guys. It's the team is excellent. And we've always have Dr. Akshay Nair as a mentor. He'll always be the mentor to all the YOSI Oculoplasty group activities. So, hi. He's also one of the judges. We'll have a proper introduction to him as well. So with this, we'll move on to, so coming to today's event, so we came up with this idea. Actually, it was Dr. Sruti, who's one of the co-moderators for the event. She came up with this title of Lights, Camera, Action Oculoplasty on. So we floated a Google form for, young ophthalmologists to submit their entries, video entries, 3 to 5 minutes videos, oculoplasty videos on, varying techniques. So we've had overwhelming 12 entries today, and, we are joined by an esteemed panel of judges as well. So over to you, Dr. Surti, to introduce our judges. Yes.
Yeah, hi. A very good evening to one and all. I hope I'm audible.
Yes, you are, Dr. Shruti.
Yeah.
Yes.
So it's a great pleasure to be always working with you. And it's again a pleasure and honor to be introducing our judges to whom we always look up to. So first and foremost, we have the young and vibrant Dr. Akshay Nair, whom I think is a perfect brainchild and a combined product of both Shankar Nethralaya and LVPI. So he's currently working at the Aditya Jyot Eye Hospital, Mumbai, and Advanced Eye Hospital and Institute, Navi Mumbai. He completed his DNB from Shankar Nethralaya, followed by his long-term fellowship in oculoplasty and ocular oncology from the LVPI Hyderabad. Then he did a fellowship in orbital surgery and oculoplastic surgery from the New York Eye and Ear Infirmary. He has 120 plus published peer-reviewed indexed papers to his credit and has given 40 to 20 book chapters. He's a reviewer, 40 plus journals. His list of awards and honors goes on and on, including, AIOS Best Paper Awards in 2011, 2021, Best Poster Award in 2013 and 18, OPI Best Paper Award in 2016 and 18, YOSI Young Ophthalmologist Award in 2020, AO Achievement Awards, and so on. The positions that he holds are the member executive committee and editor website for Oculoplastics Association of India for the YOSI. He's the editor newsletter for the Asia Pacific Society of Ophthalmic Plastic Reconstructive Surgery. He's the executive committee member of Absopris and the member editorial board for AAO One Network. So evidently he's a perfect overachiever. We are really happy to welcome you, Dr. Akshay Nair. So next we have the Wonder Woman, Dr. Maya Hada, who's basically the associate professor working at the SMS hospital in Jaipur. She has an incredible professional record, holding a gold medal in both her MBBS and MD, which she completed in RP Center AIMS. She did her senior residency in oculoplasty from RP Center AIMS again. She was formerly a consultant at the Medanta Hospital, Delhi, and she also has a huge list of awards that she has won, especially the Best Paper Poster Award at OPI 2014, Best Video Award in the British Oculoplastic Society in 2023, Professor V.K. Dada Trophy Award in 2009, Professor L.P. Agarwal Trophy in 2011, and the Best Scientific Video at many OPLs, including 2019, 2022, 2022, WS again, and OPI 2023. She is a section editor for oculoplasty in the Indian Journal of Ophthalmology and also the associate editor in IJCEO and IJO journals. Welcome, Dr. Maya. We also have a Powerpuff woman, Dr. Sonam, whom we all look up to. She is currently the consultant of Orbit Oculoplasty Aesthetic and Reconstructive Services at the Shankar Nethralaya, Chennai. She was earlier a consultant at Netradhama Eye Hospital in Bangalore. She has a special interest in ocular trauma, orbital infections, management of thyroid eye disease, aesthetics, and socket. She has many publications to her credit and has written a chapter on ptosis for Springer Publications as well. Her video on tackling the nidus won the best video at OPI 2019 and was awarded the best paper for the role of intraoperative navigation for implant positioning in secondary orbital reconstructions at the inaugural meeting of American Society of Ocular Trauma in 2021. Welcome, Dr. Sonam. So
Thank you.
without much ado, I think I'll just switch over to Dr. Nupur's introduction and to carry on the webinar.
So before we move on, a quick, comments from all the judges that, what are you looking for in today's competition? We can start with Dr. Akshay. Quick comment before we start. Yes.
No, I think we went through the Excel sheet which had the lists of participants and their topics and videos. It already seems very exciting. Things that we are looking for is clarity in terms of what the concept is and how well the surgery can be, say the purpose of this being on the YOSI panel is someone who's training in oculoplastics or who's just finished training can see this video and translate that into the OR. So clarity, ease of reproduction, your narration, and then maybe some questions that we can ask and if time permits. So that's what we are looking for.
Sure. Thank you, Dr. Akshay. Dr. Maya.
Thank you, Dr. Nupur, and the whole YOSI Oculoplasty Focus Group for having me here. It's a pleasure and honor. And truly, I'm very excited to see all these videos. Whole list of videos seems very interesting. And I look forward to learn from the young oculoplastic budding surgeons as well. And all the best to all the presenters.
Thank you, Dr. Maya. Dr. Sonam.
Thank you. Yeah, I think more or less Dr. Maya and Dr. Akshay covered what we're looking for. So yes, and also the graphics. I think how the storytelling of a video making, that's very, very important when there's a competition. That's why the title Lights, Camera, Action. So let's see how it is. Thank you.
So we have an exhaustive, it's going to be a long day, and our judges, brace yourself because we have 12 entries. So we look forward to that. And with this, let me go on to the introduction of our moderators. So this is me. I'm Dr. Nupur, and my co-moderator for today, the very dynamic Dr. Shruti RS. So she's done her MBBS from Government Medical College Theni and MS from Government Medical College Madurai. She's completed a long-term fellowship from Oculoplasty and Ocular Oncology at LVPI Hyderabad. Currently, she's a consultant in Oculoplasty at Girdhar Eye Institute, Kochi, Kerala. She's an active participant in many multiple national and international conferences. She's got a lot of awards to her credit. She won the runner-up Best Case Presentation at OPI 2023, also the Best Video Award and Best Case Presentation in YOSICon 2024, and the Free Paper Award in Orbit in the PI 2024, and the Poster Award as well. She also won the Sujata Savitri Rao Award for Best Paper Oculoplasty in the APAO AIOS 2025, and also was a Rangachari contestant. So thank you, Dr. Shruti, for helping putting this whole event together. And it's a pleasure working with you, and looking forward to moderating this whole session with you. So without further much ado, let's begin with our first participant. So the first presentation is by Dr. Neha Arora. She's currently a consultant ophthalmologist at I7 Chaudhary Eye Center. And her first video is transconjunctival lower lid senile entropion correction. So I'll just start with the video playing.
This patient is having right eye lower lid entropion with deep set eye. For this patient, retractus reattachment was planned. For that, traction suture was placed, for which I have passed 50 sil through the grey line. Using bipolar cautery, incision was marked at the lower border of the tarsal plate. Using 11 number blade, incision was placed. Bleeders were cauterized. Dissection was proceeded between orbicularis and the conjunctiva plus retractor complex. Retractor muscle was identified and dissected from the conjunctiva. To confirm the retractors, ask the patient to look down. You will be able to feel the tuck over the retractors. Double arm 60 vicryl suture was used to reattach the retractors over the anterior surface of tarsal plate. For that, box suture was used. First, both the arms of the suture was passed through the retractor. Then they are passed anterior to the tarsal plate and removed near the lash line. These sutures are like everting type of sutures. Two such box sutures were placed. Continuous sutures were placed for the conjunctiva using same 60 vicryl suture. The sutures which we had extracted near the lash line were tied. As I am tying the suture knot, you can see the eversion of the lid margin. At the end of the procedure, you can see punctum is well opposed to the globe and entropion is well corrected. You can see 1 week post-op picture. Thank you for watching.
Hi, Dr. Neha Arora. Dr. Neha, would you like to, quickly tell something about your video if you want to, before we move on to the judges for their comments?
Yes. Good evening, everyone. I am Dr. Neha Arora, consultant at I7 Preethcare, New Delhi. Today, I presented a case of elderly patient who came to my clinic with lower lid entropion. I planned a transconjunctival retractors reattachment procedure while addressing the orbicularis oculi muscle also. As demonstrated in the video, an incision was made at the lower border of the tarsus, allowing the retractors to be separated from the conjunctiva. The free edges of the retractors were then reinserted over the anterior and inferior border of the tarsus. To manage the orbicularis oculi, sutures were passed from the preseptal to the pretarsal orbicularis. This technique helps create suture track that prevent the overriding of the preseptal orbicularis. Or alternatively, a strip of the orbicularis oculi muscle beneath the tarsus can be excised along the full length of the incision for optimal result. At 1 week follow-up, you can see the well-corrected entropion which is well opposed to the globe. Thank you.
Thanks, Dr. Neha. Dr. Akshay, for your comments, please.
No, I think this is a great technique that they have shown. My only caveat would be this is in so although senile entropion is a condition that we see in the elderly, there is the elderly and then there is the really elderly, which is this is something that we see in 50s, 60s, and then the 70s and 80s as well. So this would be adequate for someone in their 60s, 50s, or 60s with mild entropion. As the patients get older, there is also a certain amount of horizontal laxity that develops, which this may be inadequate to correct. So we could always add an LTS. I was wondering, have you ever done cases where you have also done this and then added a lateral tarsal strip to this?
most of the time I always do LTS along with this. This patient I had not done it because the eye was deep set, and whenever I have tried to do LTS along with this in deep set eyes, I tend to get the gutter formation on the lateral side of the eye. So whenever I find a patient with deep set eye, I tend to not do lateral tarsal strip along with the retractus reattachment.
All right. No, I think this was well presented and good quality video. Thank you.
Thank you, sir.
Dr. Maya, your comments, please.
Nice video, nice technique, Dr. Neha. For how long do
Thank
you
you, ma'am.
keep this?
They are Vicryl. I keep them for till the time they dissolve. They just dissolve on its own. It takes around a month time, 20 to 25 days it goes off. When a patient comes after 1 week follow-up, I call the patient after 1 month. When he comes back at 1 month, sutures are not there.
And you notice little bit of, puckering at the site of the suture where you are tying over the skin. So, well, it means in Vicryl, usually we don't put bolsters, but in such cases when you are tying it tightly on the skin and you are keeping it for, say, a month long, do you prefer putting any bolster over there?
Till now, I have not put bolster, but if I'll try putting 10 seat in future cases.
Yeah, question, what do you prefer in a patient of, 60, 70 years age to go with the transconjunctival route or a transcutaneous route? Which one
I
you
always
prefer?
do transconjunctival. I have in fact never done through the skin, but I add LTS along with the retractus reattachment when I'm doing it in a patient with a lot of horizontal lid laxity.
Thank
you. Okay, thank you very much.
Dr. Sonam, your comments, please.
Dr. Neha, that was a lovely video, very nice
you.
quality, and very well explained. I think most of the questions have already been asked. So yeah,
Thank you, ma'am.
So with this, we will move on to our next entry. And 1 second. Yeah, let me just share the screen. Yeah. So our next participant is Dr. Namita Kumari. So Dr. Namita she is currently working as a consultant in oculoplasty and oncology at Shroff Charity Eye Hospital. And her video is titled Fun Turned Fatal. So let's play Dr. Namita's video.
When fun turns fatal, a pellet in the pediatric eye. There is no financial disclosure, and the consent has been taken for images and a 2.5-year-old girl presented to emergency with history of pellet injury while playing with a gun 1 day back. She had left eye swelling, pain, and inability to open the eye for 1 day. This was the gun that was used to shoot the pellet. As seen in the picture, this gun is usually used to scare away the animals, especially monkey. On examination, the child was irritable. She had left eye lower and upper lid edema with ecchymosis. The entry point was noted near medial canthus area. There was presence of a nasal subconjunctival hemorrhage. The pupil was normally reacting and the cornea was clear. The right eye anterior and posterior segment examination was within normal limits. The CT scan, axial and sagittal sections, there was presence of a highly refractile foreign body near the apex of the orbit. Intraoperatively, the entry point was noted medial to the caruncular area. A 4-0 silk traction suture was passed from the upper and the lower lid. Further, a transcaruncular incision was given using monopolar cautery. The dissection was done using tenotomy scissors, and the extent reached was posterior to the posterior lacrimal crest. The dissection was done very slowly and diligently. Care was taken not to damage the tissue. Malleable was used to retract the orbital tissue backwards. We were able to locate the foreign body. The foreign body was removed using a fine, long forceps. At this step, care is taken not to push back the foreign body further down the orbit. There was presence of a conjunctival laceration, which was sutured using 70 vicryl in an interrupted fashion. The pupil was examined throughout the procedure. Further, the transcaruncular incision was sutured using 60 vicryl. Also, the entry point over the skin was sutured using 60 vicryl sutures. This was the metallic pellet which was retrieved from the orbit. It measured around 6 mm. On fundus examination, there was presence of a small vitreous hemorrhage over the posterior pole. On follow-up, the child had visual acuity of 618 parts after 1 week, which improved to 612 after 3 weeks. The extraocular movements were full and free in all gazes. In conclusion, the children should be kept away from these things and it should be handled carefully. Orbital apex is difficult to access and densely packed with vital structures which restrict maneuvering in this closed space. Detailed anatomical knowledge with minimal invasive approach is important for carrying out such surgery. Navigation guided surgery can be done in such cases for more precision.
Thank you, Dr. Namita. That was a beautifully presented case. Anything that you would want to speak about quickly, if you just want to add something. Yeah. You're on mute, Namita. Yeah. Yes.
So I still remember the case came on I think one of the OPD days. And when the child this came, so the main one dilemma that I had that should we remove or not, because it's like it was a very at the near the apex, and I have to explain the patient that there is a chance of vision loss also. So if something there is an inert thing that you can lift, but when I go through this, because the patient has shown the pellet box. So it is a made of the lead and antimony. So I thought it's not better, it's better to remove it. And then I have explained the patient about this and also explained that there is probably the chance of that in 1% case, there is could be the vision loss. So patient said that please remove it, patient attendants. So I think that dialogue with very much important when you don't have the navigation. And also the pre-operative anatomical knowledge, and also you should be very clear what Dr. Akshay I think said in the initially that there should be clarity. So I think you should be clear before tackling the such case what you are going to do. And yeah.
Thank you, Dr. Namita. That was a beautiful presentation. So we'll take quick comments from our judges. Dr. Sonam, any comments from you?
I think that's a very nice and a very well documented case. Hi, can you hear me? I'm sorry.
Yes.
Yeah, yes,
I think that's a fantastic, very well documented case and a very good approach, very nice video as well. And very nice outcome. The child is doing well, so that's like a very good thing. I just wanted to ask, so when you're doing a transconjunctival approach and when you're going into the orbit deep, would you like to tag the medial rectus muscle as well, like the muscles in the vicinity with which
in that case,
okay.
if you will see, I was like my approach was, if you will see it was little near the apex, so I just wanted to go there, and I don't want to dissect much. So I think that in this case, I don't want to touch the medial rectus muscle because it is away from that part. And my approach I was very clear that I won't do much maneuver in this case because this is a very like critical area. Yeah. Just care should be taken for the ulnar muscle while dissecting it.
Okay. Right. And do you think like you could have, I mean, I think the outcome is fantastic, but would you have liked to also keep an ENT backup just in case you could not have reached that posteriorly? Though the imaging very classically
Earlier
seems.
we used to have the ENT backup, but not in this case, during this case. Yes, but yes, it should be there, I think.
Right, nice, but a very good presentation in total. Thank you.
Thank you, Dr. Sonam. Dr. Akshay, would you want to?
No, I think this was well presented, and I think the narration was very crisp. So I have no questions on this. Only thing is, sometimes in a limited resource setting, if you really need a quick turnaround to locate this, an X-ray is one of the few things that you can do it's one of the few rare indications in oculoplasty where an X-ray still holds value, because an AP and a lateral will actually help you localize it. When I was
actually they came with the imaging. Actually, somewhere they shown, and I think they came, and I think after 3 hours we done the surgery. And I think I am very lucky as like even the surgery got finished very, like just hardly took 20 minutes. So I think when you have the clarity also, and sometimes the luck should be also your side. Thank you everyone.
Thank you. Dr. Maya, would you want to add something?
Very meticulously done surgery. Congratulations. Very good outcome, Dr. Namita. Apart from this case, in a case of metallic or foreign body in the orbit, what is your approach? In which cases you want to intervene?
So, ma'am, there are sometimes when you have like multiple small pellets, so you can't chase and remove the every pellet. When you know that this is the pellet that is not inert. So that inert thing, I think that, and if it's in that critical area, yes, you can leave. That was even the dilemma in this case I had. So I think in that case, if it's in the critical area and it's sometimes no intervention is better than doing just intervention to show your skill. Yeah.
Thank you. Thank you, Dr. Namit, and all the
So,
judges.
ma'am, I also want to suppose that this child you know that what is the material of this. So is it the ideal approach to remove it out? Yeah, what's your take on this?
I feel if the surgeon is confident that the foreign body is accessible and you can remove it, then you should go ahead with removal. Okay, whether it's inert or whether it's metallic or organic, of course, you have to remove it.
Yes. Thank you.
Thank you. So thank you, Dr. Namita, and to all the judges. All the best, Dr. Namita. Thank you for sharing your entry with us. With this, we'll move on to our next entry. Over to you, Dr. Shruti, to introduce the next participant.
Yeah, so the next video will be of Dr. Deep Shekhar Das, who had done both his junior and senior residency from the prestigious RP Center, AIIMS, Delhi. He is currently working as the assistant professor of ophthalmology at AIIMS, New Delhi. And his video is titled A Delicate Balance, Extracting Threads and Delivering Hope to the Orbit. Can you please play the video?
Yes.
The orbit has multiple potential spaces. Firstly is the subperiosteal space, which is located in between the bony wall of the orbit and the periosteum. Then comes the intraconal and the extraconal space, which is separated by the four recti muscles. Lastly, there is a potential space in between the Tenon's capsule and the sclera, that is known as subtenon space. The importance of these spaces is that these are potential spaces in which fluid from various pathologies can easily accumulate, and thereby causing orbital symptoms. Moving to post-traumatic subperiosteal hematomas, as the name suggests, they are collection of blood in the subperiosteal space. They usually happen after trauma. So here's a case, an 11-year-old child with sudden onset proptosis. On ultrasound, we found that there is a collection of fluid in subperiosteal space. On CT scan, it is quite evident that there is a collection in the subperiosteal space in the superior orbit. So we planned for a drainage. We inserted 23 gauge needle into the subperiosteal space in the superior orbit and aspirated the hematoma. We were able to aspirate roughly 15 milliliters of blood, and immediately after the aspiration there was reduction in the apoptosis. Here are the pre and post drainage photographs. Post-traumatic orbital emphysemas occur after a fracture communicating the sinuses into the orbit. An example, a 50-year-old male presented with sudden onset eyelid swellings following an episode of sneeze. On examination, we noted that there was upper and lower eyelid swelling with palpable crepes. X-ray revealed a fracture along with air in the right orbit. NCCT also revealed the same with the fracture of the frontal sinus along with air in the right orbit. Based on the findings, a diagnosis of right eye orbital emphysema was made and plan was emphysema drainage. We introduced a 23 gauge needle and some water in the syringe, and we saw, as like in the video, evident escape of air as bubbles. Immediately there was decrease in the eyelid swellings and the patient was relieved of symptoms. Orbital chocolate cysts usually arises from orbital venolymphatic malformations, typically noted in children. They are usually transcompartmental. Here is a case. A 10-year-old female presented with sudden onset swelling in the lower eyelid of the left eye. MRI revealed multiple fluid levels and says transcompartmental lesion. A drainage was planned and 23 gauge cannula was inserted, and after taking out the blood of the chocolate cyst, bleomycin was injected inside the same cavity. So here is 4 weeks follow-up showing almost complete resolution of symptoms. Orbital abscesses are basically infections of the orbit with collection of pus in the orbital spaces, most commonly in the subperiosteal space. Here is a 10-year-old child with left eye orbital cellulitis with limitation of extraocular movements and severe proptosis. The CT scan reveals that there is a collection of pus in the superior orbit. An opening was made using a needle and pus was drained using suction. After 1 week, extraocular movements had come back. Each of these techniques emphasizes anatomical awareness, surgical precision, and patient safety, which are the cornerstones of modern-day orbital interventions. Thank you.
Yeah, that was a really nice video, Dr. Deepshekhar. Would you quickly like to talk anything about your video, Dr. Deepshekhar, if you're there?
Yeah, am I audible?
Yes.
Yeah. The whole idea of this video was to that a lot can be done just by aspirating and putting fluids inside. Like for example, bleomycin, an aspiration of maybe hematoma or altered blood for lymphangiomas, and even air can be done for orbital emphysema and even abscesses. They can be quite fruitful. We may not intervene in the sense that we don't have to do a major surgery. So that's the whole idea of this coming up with this video. That's I wanted to say. That's all.
Dr. Maya, would you like to give your comments now?
Yeah, very well documented video, Dr. Deepshekhar. And the last case of abscess drainage, it was done under general anesthesia, or it was
Yes,
an
ma'am.
OPD?
All cases have been done other than the initial two, yeah.
So the
It was
last
under
one, then you could have, changed the approach from needle to an open
Yeah.
drainage because it was a thick, collection that you were aspirating. So it would be better if you, cut all the septa with, and then you do an open drainage in that sort. Otherwise,
Usually
all
we
the
do
needle.
that. Yeah, usually we do that, but this patient there was some issues with the lack of time, and also we had to go about. We created an opening. We actually did a stab incision and created an opening, and we enlarged on it, and then somehow the pus came out. So it helped a lot.
So the results are really gratifying in all such cases when you see the, proptosis resolving on table and all. So what was the volume of bleomycin that was injected in the case of lymphangioma? Means you
In that case,
aspirated quite a bit, and I saw that you
yeah.
were injecting quite a lot. So what
No,
was
no.
the ratio?
Actually the video was edited to a certain extent. We had actually aspirated a lot more than that. We had aspirated more than 10 ml. However, we usually inject not more than 5 ml of bleomycin. Usually we don't do it. That is basically 4 ml of 4 international units of bleomycin with 1 international unit, 1 ml of lignosulfonation. That's what we usually do at RP center. So that was
Oh.
Okay. Dr. Sonam, would you like to give your comments here?
Hi, Dr. Deep Shekhar. That was like a very nice uh, full accumulation of all your cases. So very nice videos as well. So yeah, I just like to ask, like, when you're giving bleomycin, would you like to even have an ultrasound backup so that you know exactly where you're going in and make sure that you're right in the cavity, because you know there are a lot of other structures around as well.
we usually do ultrasound in most cases of all cases of in fact lymphatic malformation with chalklysis. We usually do the ultrasound just prior to injecting the bleomycin. Many a times what happens is that the instrument may not be sterile. So we do it and then clean it up. We ensure that this is the point of focus. We mark it, and then at times we go ahead and inject, aspirate, and then inject. That's what we usually do. So usually
Okay.
we routinely do ultrasound.
Okay.
Here we haven't shown, but we usually do it.
Right. So, like, it would be nice if you have the probe and then you have the visibility. So that would obviously be much better. Also, the dose, what we normally do is we generally go based on per kg body weight of bleomycin. So, yeah, I mean, that is what we follow. So, 0.5 to 1. So, how do you guys titrate and calculate that? I think Dr. Maya was also trying to ask you the same thing, right?
The idea is that we don't inject more than 5 international units, mostly at one go. So it may be required. We can inject it on a repeated basis, possibly after a month or so. What is the normal regimen which we follow? That we inject 4 international units maximum, depending upon the size and the amount of blood we aspirate, and then we keep on following the patient after 3 or 4 weeks and see how it responds. And if required, we actually get another MRI repeated. If it's visible, or even ultrasound, we do an ultrasound on a regular basis. But many times after the initial injection, when the patient comes back after after 3 weeks or so, you don't usually see that cystic space. So in that scenario, we get an MRI just to ensure that it's there or not. And if there is no obvious fluid fill space or cavity, then we keep the patient on follow-up. If it's still there, we again go on with an aspiration and injection. That's what we
Right.
usually do.
Okay. Thank you. Thank you so much.
Dr. Akshay, your comments, please, quickly.
No, I think most of the questions were asked. My only question is, in case of a fracture that is leading to an emphysema, just aspirating the air without treating the fracture, all the patient needs to do is, blow their nose or sneeze, and we'll have the emphysema back. So it's important to later on counsel the patient and also fix the fracture. In that patient, I thought on the parasagittal cut, there was a little bony fragment impinging on the superior rectus LPS complex. So maybe.
In that case, there was a fracture on the frontal sinus. There was nothing per se, because I'll just give you a brief history of the patient. The patient had a history of RTA and had gone back home, then had a sneeze, and then all of a sudden he started noticing. That is usually a typical history what happens. And in this patient, that exactly what happened. And we usually don't even aspirate in most cases of orbital emphysema. We wait for some time and it resolves. However, this patient had air which was inside the orbit, so we aspirated it. And what we usually do is that we wait for maybe a week or so. If it recurs after a sneeze, we send the patient to neurosurgery. Usually, that is what we do. This patient had come back to us without any problems. We have kept the patient on follow-up. It has been almost 2 or 3 years. Fortunately, it has the patient never had a recurrence of orbital emphysema. Otherwise, if this comes back, then again it's not up to us to do the surgery. Most of the cases, the fracture is located quite far. It's maybe in the roof or somewhere else as well. So in that scenario, it depends upon the location. We have to take assistance of the neurosurgery people.
The roof is ours, Deep Shekhar. Don't let them go to neurosurgery.
No, sir, not that. Yeah.
Nice video.
So thank you, Dr. Deep Sekhar, for your entry and the judges for your comments. And we will move on to our next entry. And so this is again by Dr. Neha Arora. We've already introduced her. We'll directly play her video. So it's LPS resection congenital ptosis. So here's a video.
24-year-old male patient had bilateral congenital ptosis. He underwent right eye ptosis surgery first. Traction suture was placed. Incision was given using 11 number blade over the marked upper lid crease. Orbicularis muscle was incised. The plane was created between the orbicularis muscle and the LPS. Orbicularis fibers were cut open. Dissection was done between orbicularis and LPS muscle. Orbital septum was recognized. Now we are incising the orbital septum and you can see the underlying fat. Now the dissection is performed between the orbicularis and the tarsus. You can see the surface of the tarsus. LPS muscle was identified and dissection was performed below the LPS muscle. Required amount of LPS was resected. A box suture is placed from the LPS muscle to the tarsal plate. Partial thickness suture was passed through the tarsal plate. The height of the lid and the counter of the lid was checked in sitting position. Later on, the knots were tied. Orbicularis to LPS to orbicularis suture was placed for lid crease formation. continuous skin suture was placed using 6-0 Vicryl. This is 1 week follow-up picture of the eye. Left eye ptosis surgery is still awaited. Thank you.
So thank you, Dr. Neha, once again. Quickly, would you want to say something about your video and then we'll move on to the judges' comments?
This was a congenital bilateral ptosis which I had presented, and the MRD1 of right eye was 1 millimeter and left eye was 3 millimeter. Patient underwent right eye surgery first, and I did it through anterior approach. The upper lid crease incision and central point along the pupillary axis were carefully marked. Following the incision, the septum was open and levator muscle was identified, and I proceeded with 14 millimeter of levator resection, adjusting both the height and counter in the sitting position. And finally, I had left the lid at 1 millimeter above the limbus. And at 1 week follow-up, the patient lid was at 1 millimeter above the limbus. And the patient came back after 1 month. The most of the cases in my hands, the lid drops back by 1 to 1.5 millimeter. So the lid dropped back and it was at 4 millimeter, 4 to 4.5 millimeter at 1 month post-op. Thank you.
Thank you, Dr. Neha. That was a beautiful video. So quick comments from Dr. Akshay and Dr. Maya on this video. Yes, Dr. Akshay.
No, I think it was a good video. Just in two quick comments is whenever we make a video and say we are presenting it somewhere or putting it on YouTube or something, it's good to use the suture name rather than the trade name. And the other thing is, any particular reason you chose Vicryl for the skin, because polygalactin or Vicryl is basically, it's a braided suture. It can cause inflammation, scarring, and even these tiny stitch sinuses. And it's better to use a non-braided, non-absorbable suture for the skin. I understand you're also using Vicryl for the levator sutures, so you already have the other end of the double armed suture. But just a notice is better to use a non-absorbable continuous suture for the skin wound.
Okay, sir. It was just while training, I was using Vicryl and it continued. That's it. No other reason.
Dr. Maya.
Yeah, very nicely done surgery. Very nice outcome also. Do you prefer sequential surgery or simultaneous bilateral
Patient
surgery?
was not willing for simultaneous.
Nice. And you, when you make the lid crease suture, when you pass that suture, you take it from the orbicularis and levator stump, and then again from the other edge of the wound. I think you
Other
should
edge of
leave
the
it.
orbicularis.
That gives a fixed fold. We don't want a fixed fold. Okay, so you can just leave that other end and pass the orbicularis to the levator stump suture, and then just close the skin to skin with the continuous.
Okay,
So that gives the dynamic fold.
Thank you, ma'am.
Thank you. So we will thank you, Dr. Neha, for both your entries. Wonderful presentations by you. Thank you, judges. With this, we'll move on to our next entry. Over to you, Doctor. 1 second now. I think there's a glitch with my laptop. Just give me a minute. So, Dr. Sonam, can you comment on this as I'm trying to fix this?
I think it's a nice shown video. I think the judges have just shared the comments. Also, I think like my preference would be to use a non-absorbable suture while, plicating or resecting the LPS. So that's what I normally use. But yeah, like it's everyone's personal choice. What do you use while you're getting your laptop done, Dr. Maya, Dr. Akshay? What do you guys use? Non-absorbable or absorbable suture for?
Yeah, during my training, I learned passing, 6-ethylon or nylon sutures. That is a non-absorbable one. But now I feel easy to handle the vicryl suture, and I don't find any difference in the outcome. So I am now, shifted to vicryl only.
Yeah, for me, I take the levator bites through with polypropylene, that is Prolene. My lid crease forming sutures are only levator and pretarsal orbicularis in a horizontal mattress. So that is the only thing that I use polygalactin or vicryl. Skin is again with Prolene. The advantage for me is I still have these cases where, 1 in 10 or 15, where I end up having to revise for overcorrection, undercorrection, and sometimes they come back a little later after 3-4 months, where it may be difficult to find a pre-placed suture. The advantage of a non-absorbable suture is I find the knot and I know I need to go a little higher or lower in that case. So also, the non-absorbable polypropylene tends to incite a little less inflammation. So that works well for me.
Right. Thank you.
Thank you. I'm sorted with my laptop. So yeah, we'll move on with the next presentation. So over to you, Dr. Shruti, to introduce our next participant.
Yeah, so next we have Dr. Urvi, who is currently pursuing her fellowship in oculoplasty at KB Haji Bacholi Eye and ENT Hospital, Mumbai. So quickly we'll switch over to her video and then we'll get her comments. Yeah.
Yeah, just 1 second. I just need to share the screen again. Yeah, the audio settings are on. Yeah. Yeah.
Unmasking the silent growth, a case of orbital cavernous hemangioma with surgical insights. Patient presented to us with right eye progressive painless axial proptosis since 6 months with clinical findings showing upper lid retraction and inferior scleral show. MRI findings showed a well-defined lobulated mass in the central and medial intra and extracorneal compartments of the right orbit with DDs as cavernous hemangioma and schwannoma. Patient was induced under general anesthesia, after which peribulbar block was given and subconjunctival anesthesia was infiltrated. Peritomy was done inferiorly, followed by blunt dissection. Inferior rectus muscle was identified and hooked. After tagging proximal and distal ends of inferior rectus with 6-0 vicryl for better exposure, the muscle was disinserted. With transconjunctival approach, it was possible to reach up to the mass. A cryo machine was used to get hold of the mass, and with to and fro movements, the mass had to surpass the surrounding adhesions, and it was got onto the anterior surface of the eye. With bipolar cautery, partial hemostasis was achieved for the stump of the lesion, and with the help of a monopolar cautery, it was excised. Betadine-soaked earbuds were kept in the area from where the mass was removed for 3 minutes. The distal and the proximal end of the disinserted inferior rectus was reattached with 6-0 vicryl. The inferior perilimbal conjunctiva that was dissected earlier was approximated at 9 o'clock and 3 o'clock position with 6-0 vicryl. Subconjunctival anesthesia was re-infiltrated, forming a bleb and repositioning the conjunctiva well. The lesion measured about 2.5 by 2 by 1 centimeter. This is how patient presented on day 1, day 7 and after 1 month. Histopathology on gross examination described a well-circumscribed encapsulated lesion measuring 2.5 into 2 into 1.5 centimeters with microscopic findings proving to be a cavernous hemangioma. Now we know that orbital cavernous hemangioma is a benign, non-infiltrative, slowly progressive vascular neoplasm surrounded by a well-delineated fibrous capsule, commonly presented in women with age 20 to 40 and with no evidence of a inheritance pattern. Pregnancy can be one of the risk factors which is associated with accelerated growth of pre-existing cavernous venous malformations and pathological findings of the mass being composed of dilated cavernous vascular spaces separated by connective tissue stroma.
Thank you so much, Dr. Urvi. If you're connected, would you like to tell something quickly?
Evening, one and all. Thank you for having me here. So we thought of operating this patient as she had a significant axial proptosis and visual deterioration from finger counting half meters, and post-op she was 6'6". She had extraocular movements restricted superiorly, and even dilated fundus, we could see elevated disc margins. So had it been a small lesion where there was no visual deterioration, we would have observed. But as you all saw, one more thing that it was intraop, we could see the dilatation of the pupil. So that is one of our concerns too, that even the anesthetist and us, we are figuring out it is because of maybe some drug, which we haven't found out yet. Thank you, ma'am.
I think it was a peribulbar anesthesia.
But so that was 3 ml only. And
So that for me is a red flag. Visual deterioration, disc edema, all suggest compressive optic neuropathy or at least abutting the nerve. In which case you know that probably there's some adhesion or it's close to the nerve. And to inject lignocaine and adrenaline in that patient, even a 1 ml, takes away the possibility of you detecting intraoperative pupillary dilatation. So for me, using lignocaine with adrenaline, you can use it post-op for post-op analgesia. But as you can see, it has little or no role in hemostasis intraoperatively. If it has to bleed, it will. And those bleeders are from large connector feeders to the vascular malformation. So, that's just a pointer to keep in mind. Unless, if you want to do it in the lateral canthus for a canthotomy, cantholysis, and a little hemostasis, go ahead. But subconjunctival or intraoperative or peribulbar adrenaline with local is a no-no, because then you lose the ability to detect subtle intrapupillary dilatation. But otherwise, it was a very well done surgery. Huge mass through a small incision, scarless, nicely done.
Thank you so much, Dr. Akshay, for that clinical pearl. We'll get the comments from Dr. Sonam as well for this video.
Yeah, I think it was a very well presented case. Just a pointer, like if you want to attain hemostasis, we can use brimonidine also before the surgery while you're going through a transconjunctival approach. So that will help a little bit. But otherwise, I think everything. But just a question, do you think without disinserting the inferior rectus muscle, you would have been able to remove the mass?
My mentor did try doing it, but after a point we had to disinsert because we couldn't get hold of the lesion completely because it was in centrally, medially, and inferiorly. So that is when we thought of inserting the muscle.
Right. All right. Thank you. It was a good case. Nice surgery. Thank you.
So thank you, Dr. Urvi and judges for this comments. We will move on with our next entry, and our next participant is Dr. Deepsekar. We've already introduced him, so we'll play his video, which is titled "The Silent Sculptor: Autologous Fat in Orbital and Periocular Deformity Repair." So here's his video.
We have no financial disclosures to make. Autologous fat graft has been used in recent times in orbital and periocular conditions, with the indications being periocular scars causing entropy and ectropion, thysis bulbi in ophthalmos and ophthalmic socket with sulcus deformity. The common areas from where the fat is obtained are the abdomen and the thighs. In this first video, we are going to show you how it is obtained from the abdomen. So first, an infiltrating anesthesia is given using a 20 cc needle in a fan-like distribution, where you use a spindle needle for ensuring that the anesthesia is administered in the subcutaneous fat compartment. We also have a photograph. Here you can see how and which plane the lidocaine is being placed. Endpoint is firm filling of the skin. Then, using a 11 number blade, we create an incision, and using the Coleman's fat aspiration cannula, we slowly make to and fro movements while we stabilize the fat pad with the other hand. Along with that, we also aspirate using a cannula. Now we transfer the harvested fat using a 3-way cannula to another syringe. In this, we can actually see what are the different layers of fat. Now coming to the fat processing, that is the Coleman's technique. We first decap the syringe and the plunger, and we place it for centrifugation. Centrifugation is performed at 3000 rotations per minute for 1 minute. On to how the fat is transferred to the eyelid. First, a local anesthesia is given in the lateral canthus, and then a vertical stab incision is made at the lateral canthus. Adhesions are then released using 20 gauge liposuction cannula. Free space is created in the subcutaneous plane throughout the area of the ectropion. Space extends superiorly up to the eyelid margin and inferiorly up to the orbital rim. Then the cannula was flushed, attaching to a fat-filled syringe. The fat was then placed in the freed space, starting from the medial end to the lateral end, injecting at multiple points. It was ensured that maximum amount of fat was injected at the severest degree of ectropion site. Injection was done in several fanning passes to avoid fat clumping. The cannula was removed and bandage was put. Here are the pre and post injection photographs showing correction of ectropion. Moving on to fat in periocular scars. Suction based liposuction is done from the inner aspect of the thigh. Lipoaspirate decanting based on density is performed, and then preparation of microfat is done. Transfer of millifat from port 1 to port 2 syringe using a one-way valve, and then of the microfat is performed by flushing it between port 2 and port 3 at least 10 times back and forth. And the fat is ready. We inject the fat in the subcutaneous plane just underneath the scars, fill places using the 20 gauge cannula. We also break adhesions using the same. This is how exactly we are going to inject. We should inject in all the areas of the scar using multiple entries. So these are the pre and post injection photographs. Moving on to autologous fat in thysis bulbi, here are certain images of our patients. Pre-injection, you can see that there is enough thalamus, and post-injection it is gone. Moving on to autologous fat graft in superior sulcus deformities. Patients who have undergone enucleation or evisceration, many times we see this. So here are our pre and post injection findings with obviously positive outcomes. Coming to the limitations, there is need of expertise and equipment, and fat may not stay there for long, and patient needs to be counseled for donor site related complications.
So again, a wonderful video from Dr. Deep Sekhar. Would you want to quickly, say something? Deep Sekhar, are you there? Yeah, hi.
Yeah, am I audible?
Yes, you are. Yeah.
The whole purpose of this video was to basically visually demonstrate the various techniques and outcomes of autologous fat graft for correction of orbital and periocular deformities. So we are doing it for some time. So we just wanted to share the experience. That's all.
Very nice. Thank you. So quick comments from Dr. Sonam and Dr. Maya on this. Dr. Sonam, yeah.
Um, Lovely video, and the technique is fabulous, Dr. Deep Shekhar. I wanted to ask you what's the long-term follow-up? What's like how much percentage resorption do you observe? What's your longest follow-up in these cases?
Longest follow-up which we have is roughly 1 year as of now. The ones depends upon the cases we are talking about. When we're talking about thalamus, we initially started off with treating thysis eyes with injecting fat, and that was started roughly 4 years back. And we had patients which had come back up to 1 year, where again they started developing the superficial deformity, and they have started again developing thalamus again. So we needed to give them injections on a repeated basis, maybe twice or thrice. But then again, the process is quite cumbersome, and due to which it depends upon the cases actually. When it comes to rejuvenation of the periocular scars per se, we are having good decent outcomes. We have recently started it. I think 7 months we have postdocs, and they're doing quite well.
And have you tried mixing PRP along with autologous fat for
Yeah,
injection?
we are about to start
Or
that.
any
We haven't
experience?
started. We are just about to start a research on that. We already have something, but we're going to show it maybe afterwards in future possibly. We have something
Last question. Why not fillers?
Ma'am, the patients which we are catering to is basically they are not that well to do. Okay, and fillers are quite expensive even in modern day scenario. At least when the patients which are coming to AIIMS Delhi as of now are not willing for paying, that much of bucks from their pocket. So that's the thing. So as of now, maybe in future, possibly, I think Akshay sir is having patients who are having, possibly sir has more experience regarding all those kind of fillers and this thing, even fats as well. Sir will be the person to comment on this better.
For a second, I thought Akshay sir has got enough fat to donate. I said, yeah, that is also correct.
So, yeah.
So I think I'm unable to see Dr. Maya on the screen. Dr. Akshay, would you want to comment on this video?
Yeah, I think a couple of things. It's a nice presentation. The concept is explained. Just a few tips is to use something known as a Klein solution, KLEIN. You can look it up online. That's lignocaine with normal saline, adrenaline, and soda bicarb in a fixed proportion. That is exactly the contents of the tumescent anesthesia, very well described. I think here the indications were for volume correction in terms of for post-traumatic fat loss or volume loss, where you really need to go under the muscle and pre-periosteally or on the muscle. But when we talk about for aesthetic indications, there's a difference between microfat and nanofat.
And the nanofat.
Yeah, the filter that you showed to change the pore size is very correct. The only thing, injection of microfat is subdermal using either blunt needles or cannulas. And when you do nanofat, it's only with needles and it's injected intradermally. And
we also have a separate applicator for it, where we just keep on rubbing it. I haven't shown it in the video because of the paucity of time. So otherwise,
and in the orbit, like you've done it in the post-op picture, you could see it, which is the right thing. It's always a good idea to overfill by about 30% of the expected volume, because in the orbit, there's always a little more resorption as compared to other areas. So, but a great concept and nicely presented.
thank
you. And one more thing, always use Luer lock needles. Sometimes we don't
Yeah.
have them for 10 cc's and 5 cc's. Procure them. Fat cannot be done without Luer lock needles, Luer lock syringes.
Yes, yes.
Thank you. Thank you, Dr. Deepsekhar, for both your, wonderful submissions. And thank you, judges, for the comments and the discussion. We will move on to our next presentation. Over to you, Dr. The next participant.
Yeah. So next we have Dr. Shalin Sunil Shah, who is currently the head of Oculoplasty, Ocular Oncology and Aesthetic Services at the SNEH Care Vadodara. And his topic is named Orbitotomy, Opening Up the Pandora's Box. So we'll quickly play his video.
Hello everyone. Let's have a look at the various surgical approaches into the Pandora's box. We have a middle-aged lady with long-standing proptosis of left side. Imaging shows a large well-circumscribed intraconal mass in left orbit, pushing optic nerve superomedially. The ideal approach is lateral orbitotomy with bone wall removal. A limbal peritomy is done and the lateral rectus muscle is tanned. Lateral canthotomy is followed by a Rees-Burke incision for lateral orbitotomy. The soft tissue is dissected and the periosteum is reflected to expose the lateral orbital rim. The frontozygomatic suture is an important landmark here. A bone saw is used to make two parallel incisions and a bone window is created. The lateral rectus muscle is clamped and disinserted. The intraconal space is open to expose the mass. The orbital tissues are bluntly dissected and the mass is delivered out of the orbit. After achieving hemostasis, the bone piece is positioned into place. The periosteum, muscle and skin are closed in layers. Next in OPD is an elderly male patient with inability to open right eye. The patient shows significant enophthalmos with superior orbital mass. Imaging shows a superior orbital mass extending into the frontal sinus. There is a complete obliteration and ossification of sinus ostium with no communication into nasal cavity. Endonasal endoscopic assessment shows loss of all bony landmarks following prior FES surgery, with complete opening of ethmoid and sphenoid sinuses. The patient is planned for a superior orbitotomy with vertical lid split approach. The skin incision is made to expose the tense cystic swelling. Surrounding soft tissue is gently dissected from the cyst wall. Cyst rupture is noted during deeper dissection. The purulent contents are aspirated. The remaining thickened cyst wall is excised. After adequate hemostasis, the lid margin is repaired and wound is closed in layers. The patient shows a satisfactory resolution of enophthalmos and ptosis, with no recurrence during follow-up visits. Our next case is a 41-year male patient who complained of painless swelling below right medial canthus for more than 4 years. The patient had a history of external DCR surgery done 2 years back, which failed within 2 months. On examination, we notice right globe dystopia with globe pushed out and upwards. Roplast test is negative with a soft stop on probing, suggesting an encysted mucocele. Imaging shows a well-defined homogeneous non-enhancing mass in right orbit extending along nasolacrimal duct. The patient was planned for an infiromedial orbitotomy with complete mucocele excision and re-DCR surgery. A modified Weber-Ferguson skin incision was used for. The skin flap was raised to expose the tense cyst underneath. The mucocele was completely excised and nasal cavity was opened for re-DCR surgery. The patient had an uneventful recovery with no epiphora over a 9-month follow-up. Histopathology showed findings consistent with mucocele. These patients may often develop enophthalmos, ptosis or residual strabismus, which needs to be addressed individually in the subsequent sitting.
Thank you so much, Dr. Shalin. If you are connected, can you please quickly give a few comments?
So, hi, hope everyone can hear me. So this video I had made just as a reference for, uh, my colleagues or people who just want to know the basic steps of an orbitotomy, because when I was learning, I could not find many videos of these kind, and so that's why I started recording my surgeries and editing my videos, and that's why I put it up on the forum.
Okay, so we'll quickly get Dr. Sonam and Dr. Maya's comments on this video. Dr. Sonam?
Shalin, very nice videos and nice outcomes as well. I just wanted to ask you, like in the post-op period for your first case, there was a exotropia also. So, did the patient have vision? Was there any muscle injury? What?
She had a mass over 4 years, so she had developed optic atrophy in that eye. At presentation, her vision was PL positive, PR accurate. She improved to 3/60 at the end of 3 months. She was counseled for a strabismus surgery followed by a ptosis surgery, but she did not actually want them. She's around 50 years old now, so she did not really want the cosmetic correction.
Okay, fine, nice. And also your choice for lid split procedure. Just wanted to ask you about that. So, would you prefer a lid split over an upper lid crease or a transconjunctival, or what over
I
the?
had considered a transconjunctival approach for that patient, but I actually wanted a very decent exposure and I did not intend to rupture the mucocele on table. I wanted to dissect it as far as possible because it's an infected content, and the more I spill into the orbit, the higher chances of post-op orbital cellulitis. So I wanted an absolutely open orbit when I was dissecting it out. That's why I went for a lid crease approach. Of course, it may give a disfiguring scar, but fortunately, the skin was quite forgiving in this patient, and he has minimal scarring, and there's no lid notching. So,
Right. Lovely cases, very nice videos. Thank you.
thank you, ma'am.
Thank you, Dr. Sonam. Dr. Maya, could you please give your valuable comments?
I'm so sorry, Shruti, because of the technical glitch, I missed this. I have to see the recorded video, and I've switched on to the next device, and I'll be, okay, online now.
Dr. Akshay, can we have your valuable comments, please?
No, I think it was very well presented. All the cases were extremely well done. I have nothing to add. I think Shalin is presented all these scenarios of orbitotomy very well. So only thing is that maybe in the mucocele, do you think you could have aspirated it first? So thereby the incision size could have been a little smaller.
Yes, sir. But actually, I had this case taken up with my ENT colleague, and the frontal bone, I mean, the roof of the frontal sinus connecting to the cranial fossa, anterior cranial fossa, was also quite thinned out. So we both agreed that in case our needle goes an or two just beyond, we might just hit the dura. So we decided to leave it intact and just dissect it gradually and remove it in toto. But unfortunately, while dissecting near the frontal sinus ostium, there was some fibrosis which caused the mucocele to rupture.
So thank you, Dr. Shalin, for that, wonderful entry of yours. And thank you to judges for the wonderful, insightful discussions. Now we move on to our next end participant. And this is by Dr. Urviva. We've already introduced her. So she'll be presenting a case of CIN, and this is her video.
A lady presented to us with left eye painless, progressive, slow growing conjunctival mass since 6 months. On examination, there was a 10 mm by 7 mm conjunctival lesion with intrinsic vascularity and feeder vessel and keratin deposits in the temporal quadrant. Under peribulbar block, wide local excision with a 5 mm margin was planned. Distance of 5 mm was marked from the lesion with the help of a scale. Local excision of the lesion was performed with the help of a monopolar RF cautery. The lateral end of the lesion was tagged with a 6-0 vicral suture, which also served as a traction suture. Hemostasis was maintained with the help of a bipolar cautery. On the corneal aspect, superficial keratectomy was done with the crescent and the lesion was removed in toto. After removing the lesion, cryotherapy was performed in an overlapping manner so that there are no skip areas. An adequately sized amniotic membrane is sutured to the margins and to the sclera. To prevent the foreign body sensation from the sutures, a ring conformer is placed and a median tarsography is done for 1 week. The margins of the lesion are tagged with different types of sutures like ethylon for inferior, vicryl for lateral, proline for superior, and scent for histopathology.
Thank you, Dr. Urvi, for that once again a beautiful presentation. Would you want to quickly say something, add on to it?
So ma'am, this lady, 74-year-old, who presented to us with the slow growing interpalpebral conjunctival region, had very peculiar features of OSSN, like intrinsic vascularity, feeder vessels with the keratin deposits. And being a localized lesion, papillomatous lesion, we thought of going for a no-touch technique. And we've used double freeze thought cryotherapy in it. Yes, that's it.
So yeah, so quick comments from Dr. Akshay and Dr. Maya on this. Yeah.
Yeah. Would you consider using glue instead of sutures? So then that doesn't need a conformer and a tarsorrhaphy as well. And yeah, and the other thing is for we are doing an alcohol. We are doing a keratectomy to make sure that any corneal extension is removed, but we can't cryo the cornea. So if there is a corneal extension or some residual cells are left behind, to take care of that, we can always use alcohol that not only denatures the epithelium, but also kills any viable cells there. So an alcohol-assisted keratoepithelectomy is good. And just a practical tip is to use a cataract drape, and in these cases with the speculum, and especially while excising the tumor, you can have your assistant with a 10 or a 20 cc syringe filled with saline, constantly hydrating the wound, basically putting saline over the region while you're excising. So that way it takes away all the blood and goes into the side pocket, and your assistant doesn't have to keep dabbing it with a bud, because any kind of contact with the tumor is potentially displacing cells from that. So apart from that, I think it was a very well presented and well managed case.
Thank you, Dr. Akshay, for those caveats. Dr. Maya, would you want to say something?
Yeah, Dr. Urvi, very well managed case. And I echo with the thoughts of Dr. Akshay that you could have used either AIDS or micro suture, or you could have used glue, because putting a symblepharon ring for OSS and excision is not warranted. And other than that, cryo at the base, I think the sclera was already been cauterized a lot, and then doing a cryo over limbus also put the patient on, limbal stem cell deficiency and sometimes scleral melt also. So doing so much of, cautery and cryo is not warranted. So you could avoid that.
Thank you. Yeah, thank you, Dr. Urvi, for both your presentations, and hope you'll, keep participating in the YOSI activities with the same enthusiasm in the future also. And thank you, judges, again for the insightful discussion and your pearls of wisdom. With this, we will move on to our next entry. Over to you, Dr. Shruti, to introduce our father. Yeah.
So next we have Dr. Kanchan Sharma, who is currently a second-year DNB resident at the Eye Care Eye Hospital and PG Institute, Noida. Her topic is tackling the dermoid.
Hello everyone, today I'll be discussing dermoid cyst excision. So it is also known as congenital choristoma, which arises from entrapped epithelium during fetal suture closure. Most common site is frontozygomatic suture. It is lined by keratinized squamous epithelium and contains hair follicles, sebaceous sweat glands, smooth muscle and fibroadipose tissue. Most common orbital tumor in children, that is 46%, and it is seen as a firm non-tender mass. Now, for diagnosis, we need CT and MRI for deep lesions, which is seen as well circumscribed hyperdense wall, hypodense content, and treatment is mostly surgical excision, which is definitive. So this is a case of a 4-year-old child who presented with left external angular dermoid. The CT scan is showing the dermoid, and there is no internal component in this case. So this is the procedure where first the incision is marked under general anesthesia. Dermoid is gently excised from the surrounding tissue using blunt and sharp dissection, carefully ensuring that the whole dermoid comes out in toto without getting the walls of the cyst ruptured. Now it is carefully extracted from its base, and it is sent for histopathology for further confirmation. Now, cautery is applied to achieve hemostasis to prevent any further hematoma formation. So first, to close the deeper tissue, we use absorbable suture like Vicryl and put interrupted buried sutures. The aim is to approximate the wound edges so that to decrease tension on the skin closure. Then skin is closed using 6-0 Vicryl sutures, where interrupted sutures are put, taking equal bites of skin from each wound edge at 90 degrees. So this is the poster picture of the same patient who appears to be happy after the excision. Thank you.
Thank you so much, Dr. Kanchan. If you are there, would you like to tell something about your video?
Yes, sure, ma'am. So, good evening, everyone. Myself, Dr. Kanchan Sharma. I'm a second-year resident at Eye Care Hospital, Noida. And I've chosen this particular topic as we have commonly encountered dermoid cysts in our OPD, and I've got the opportunity to assist this case with Dr. Nupur, ma'am. So, clinically, superficial cysts are more common and benign, while the deeper dermoids tend to cause proptosis and globe displacement, though less commonly seen. So imaging is particularly very important in these cases so that to rule out the deeper component, if any. Like in deeper cysts, once we have seen a dumbbell-shaped dermoid, uh, complete surgical excision is the treatment of choice, as incomplete removal can lead to recurrence or inflammation due to cyst rupture.
Thank you. Dr. Maya, your quick comments, please.
Yeah, very nice surgery and very joyful video.
Thank you, ma'am.
The joy of taking the dermoid in toto is always so pleasurable. You recorded the surgery from the screen with your mobile. You didn't get the recorded this thing.
Ma'am, the video was too long, so
Kanchan?
I had to cut it down and then edit the video accordingly. It was a 1 hour long video, so I had to do some editing to get that. I was assisting the case to Dr. Nupur ma'am only, so it's the
No,
same
I
surgery
am
which I've
saying that
cut. Yes,
the
ma'am.
recording was from the screen, not
Yes, ma'am. It
directly
was.
from the microscope. I guess so.
Yes, ma'am. The suturing part actually, it's because of my editing skills. It was a 1 hour long video, so I had to cut it short to get it done for within 3 minutes. So I was recording it on my laptop. I had the video on my laptop only.
Okay, I got it. All right.
Yes, sir.
So
Yes, sir.
basically, she submitted this video last minute. I wanted her to present, to get a feel of getting a presenting the thing. So she did it last minute. So the file was too heavy for her editing software, and she's still learning to edit. So that's why she said, "Ma'am, I put it on the screen and then just edited those parts because it was not getting transferred on InShot. She does the editing on her mobile. So with time, I'm sure that they'll learn to use better softwares for editing.
Definitely.
Yes,
Definitely.
that's what I wanted them to have this exposure of, see
Yes,
how others are
absolutely.
presenting, and yes.
Wonderfully done. Yeah.
Thank
Nice.
you, ma'am. Thank you, ma'am.
Very good effort, Dr. Kanchan. Next, can we have Dr. Sonam's comments also, please?
Kanchan, fabulous second year DNB presenting in a subspecialty forum. Kudos, Dr. Nupur, for actually pushing your PG to do that. Very nice surgery, very well managed. So yeah, that's all. Post-op also, the child is so happy with it. So that's all. Just a question: if you have a dumbbell dermoid, how would you want to manage a dumbbell dermoid? Since you mentioned about it.
Yes, ma'am. Ma'am, I have not seen it surgically. So
What's the most common location where probably you'd find a dumbbell dermoid?
Ma'am, most common is frontoethmoid suture only, ma'am. The
Okay. You normally find it in the along the lateral orbital rim, the double dermoid. So, but anyways, very nice. Thank you.
Thank you.
Thank you. With this, we'll move on to our next presentation. Thank you, Kanchan, for the efforts. And I think it's a lesson for all the residents, YOSI is for you guys. Come out and present, it's the effort that matters. It's for you all to learn, getting exposure to such forums. That's how you become better by learning. So with this, we'll move on to our next
Hello, everyone.
presentation. So next is Dr. Swati Agarwal. And so Swati has completed her fellowship from Shankar Nethralaya, Chennai in orbit-led reconstructive and aesthetic services. And she's currently working at Meerut, Muzaffarnagar and Bareilly at various centers, and also has her own Swati Eyeplasty center. So with this, we'll move on to Dr. Swati's presentation, which is titled Above and Beyond Tumor and Orbital Roof. So this is her video.
A 19-year-old boy visited to the OPD with a history of left eye droopiness since 5 years. On examination, there was a fullness at the supromedial orbit, but the extraocular movements, pupil and the fundus revealed no abnormality. CT scan orbit was ordered to reveal an extensile bony lesion. Left eye superior orbitotomy was performed under general anesthesia. Upper lid subbrow incision was made and the tissue were dissected to expose the anterior part of the bony lesion. Thin, encapsulated fibroosseous lesion was noted in continuation with the periosteum of supromedial orbit. Hemostasis was achieved with a bipolar cautery. The superior part of the periosteum was dissected and incised to expose the bare bone. Anterior wall of the orbital lesion was chipped off and the loosely woven fibrous bone was removed in a piecemeal fashion. After debulking the superior orbital part, the medial part was also opened and debulked. An electric mini drill was used to further break any septations or trabeculae in the lesion and to smooth the sharp and irregular margins of the orbital wall. On completion of debulking, a betadine wash was given with a perilesional steroid injection and the wound was closed in layers. The specimen was submitted for histopathology, which revealed it to be an ossifying fibroma. The patient is doing extremely well post-operative.
Thank you, Dr. Swati. That was such a nice presentation in a video. Would you want to quickly say something, add on to what you've presented? Yes.
Yeah, first of all, good evening, all the dear judges, and it's lovely to see Dr. Sonam, Dr. Akshay, and Dr. Maya Heda. Missed seeing them in OPI. So this young male, he was applying for UPSC examination and he wanted to be in police academy. So he had cleared his exams and he was due for his physical, and he was a little concerned for ptosis for that reason. He didn't have any visual problems as such. So, and he is doing good and he's very satisfied with this outcome. And I would like to ask our dear judges that would any other approach they would take or their any wisdom pearls they would like to share in this case.
So Dr. Akshay and Dr. Maya probably can take this up. Yeah.
Yeah, I mean, I think it was a well presented case. I mean, since in imaging we know it's not like a malignant lesion, we could think of a lid crease approach also rather than a subbrow approach, so we avoid the scar. Because apart from the suborbicularis dissection that you do, you anyways reach the periosteum and the rim. But yeah, you need a little more of assistance from your assistant to retract and hold it in place with a with a lid crease incision. Yeah, apart from that, it was well presented, and I think as long as the lesion, it was a ossifying fibroma, they can recur.
They
But
can
apart
recur.
yeah, apart from
But
that,
do we need a neurosurgeon backup also in these cases?
not really. If you see that there is no thinning of the bone, I mean, this is rather than thinning, you would see thickening of the bone. The only thing is you could additionally use is if you've excised the lesion and if you still see ragged edges, you could use a drill to just gently smoothen out the edges and make sure that there are no ragged edges or facets that can be a little sharp there. Apart from that, nothing else. And as long as you're on the outer table, there's still the inner table, and especially in the lateral canthus, there's very, very thick bone, the door jamb. That's basically what we do
Called
in a
the supromedial mass.
sorry, not supramental. So yeah, so there, yeah, probably you need to be a little more careful when you go medially. But as long as you're on the outer table, you're relatively safe superiorly.
Thank you. Dr. Maya, any comments?
Yeah, Dr. Swati, very well done surgery. And I agree with Dr. Akshay that there is an outer table and you don't have to, you don't have that risk of reaching the dura or having any neurosurgery backup. You just have to be careful about the supraorbital, that bundle of the neurovascular bundle, because your lesion was very near to that. And other than that, you have done a very good job. Nicely done.
Thank you. Thank you, Dr. Swati, for that wonderful submission of yours, and to the judges for the discussion. We will move on to our next participant, and I'll request our next participant. Over to you, Shruti.
Yeah. So next we have Dr. Nisha Beniwal, who is currently a postgraduate DNB resident at the Eye Care Hospital and Postgraduate Institute, Noida. So her topic is From Trauma to Triumph, a successful canalicular tear repair. Over to the video.
Whenever we see a patient with trauma, the primary management should start with stabilizing the patient systemically. Then we see whether the globe is intact or not. If not, then we first repair a ruptured globe prior to the definitive evaluation and management of eyelid or nasolacrimal trauma. If the globe is intact, the diagnosis of canalicular laceration may be confirmed by introducing a fine Bowman probe into lacrimal punctum and out through the wound. Recommended time of canalicular repair is within 48 to 78 hours of injury, as later on fibrosis sets in. The nasal cut end of canalicular laceration may be difficult to identify, so we can do so by using a Bowman's lacrimal probe, in which we follow the natural course, or we can see the whitish circular opening of the canaliculus or lacrimal sac, which is known as the calamary ring sign. Or we can inject a fluorescent impregnated saline or air into the opposite punctum and simultaneously observe dye appearance or bubbles. Or we can also use a pigtail probe. So the surgery begins with first giving the local anesthesia, and in our case, the child was taken up for the surgery under general anesthesia. Then we dilate the punctum using the punctum dilator and identify the distal end by inserting the Bowman's probe. Then we take the silicone monocalalicular stent. The end was cut, inserted into the distal end and pulled out from the other side. We identify the proximal end by calamary ring sign, and then mini monoca is being inserted into the proximal end of the canaliculus. As we can see, it is going easily into it, which is a clue that we are in the right passage. Otherwise, it tend to coil or not move into it. Then we pull its distal end and it gets plugged into the puncta. Then we close the tissue using 6-0 vicryl sutures. The needle is inserted into the proximal end followed by the distal end, and as we tie the suture, both ends should approximate towards each other. We close the wound and bring the lacerated lid back to its original position. As we can see, left lower lid mini Monoca in place at 4 weeks post-op, and after that it was removed and patency of lacrimal drainage system was checked. And these are the pre-op and post-op pictures of the patient at 6 weeks after removal of the canalicular stent. Thank you.
Thank you so much, Dr. Nisha, for participating. Can we, if you are connected, can we have your quick comments, please, on your video? And then we'll move to the judges.
Good evening, ma'am. Myself, Dr. Nisha. I'm a second year DNB resident in Nicare Eye Hospital. I've also assisted the surgery with Dr. Nupur Goyal, ma'am. So the purpose behind taking this procedure was that it is more than just an anatomical reconstruction. The canaliculi play a vital role in tear drainage, and even a single torn canaliculus, if left unrepaired, can lead to chronic epiphora, recurrent infections, and significant patient discomfort. So timely and appropriate repair helps to restore the normal lacrimal function and improves the cosmetic outcomes and even prevent the long-term complications. So while the surgery itself may seem subtle, its impact on quality of life is profound.
Yeah, that's very true. Can we have Dr. Akshay Nair and Dr. Sonam for their valuable comments here? Dr. Akshay?
Yeah, no, I think it was very well presented. A couple of things that I really liked was holding the mini Monoca with a needle holder, which is non-traumatic. So that's a good thing that you did. Apart from that, I think everything else was done well. It also helps to cut the mini Monoca usually is 40 mm long, and we don't need that much in a child. So to cut the end, you can cut it at an angle such that there is a bevel. That bevel helps in guiding it. And also, if the child is under GA, you could always put the suction cannula in the nose. And once you've identified the distal cut end of the canaliculus, just irrigate a little, either with fluorescein or plain saline. Once you see it in the nose, then you know that that is the opening and not a false passage, because sometimes you really can get muddled in that. Also, you could use a drop of slightly diluted adrenaline that blanches everything else, and you see the calamari sign really well. But I think you've covered all the points and ticked all the boxes. Very well done.
Thank you.
Diluted adrenaline, or can we use brimonidine alpha-GAN eye drops, Dr. Akshay? Yeah. Dr. Sonam, for your valuable comments, please.
Dr. Nisha, very nice video. Like Dr. Akshay said, you've covered everything. So yes, I think you've covered more or less everything. Sometimes you can even use a pigtail probe if you don't find it, though I find it very traumatic. But at the end of the day, if you can't find it, then that's also a very good tool to identify the other content. So yeah, that's all. Thank you.
Thank you.
Thank you, Dr. Nisha, for your efforts, and and to the judges for your valuable comments. We'll move on to our last but not the least presentation for tonight, and this is Dr. Priyanka Valvekar. So she has completed her fellowship from LV Prasad Eye Institute, and she's currently working at Narayan Netralaya, and her video is titled Utility of Reverse Impression Cytology in Ocular Surface Tumors as a Simple OPD Procedure, and this is her video.
Hello everyone. Today I will be taking you through a technique, reverse imprint cytology, that has its utility in playing a key role in diagnosing ocular surface tumors. Let us first take a look at this photograph. Clinically, based on the features of a perilimbal lesion and intrinsic vascularity, one would suspect a papilloma or a papillary variant of ocular surface neoplasia amongst other differentials. In such situations, an adjunctive tool to pick up the features of dysplasia to rule in or rule out tumors would aid in the treatment plan, especially where clinical examination alone is not confirmatory of the diagnosis. RIC is a cost-effective OPD procedure with easy access in diagnosing surface tumors, and it creates a reverse impression of the imprint on the filter paper, which is then mounted onto a glass slide. Traditionally, as we all know, while performing the impression cytology, we send in the charged nitrocellulose paper itself for the analysis, which can be tedious to analyze owing to the procedures of destaining and requiring quicker transit time, apart from being a challenge to analyze under light microscopy, as the paper needs to be made transparent and then read. Keeping it more than 60 minutes at a time can pose issues with analyzing the cytology as demonstrated here. In the technique of RIC, the charged nitrocellulose paper is initially cut into a tongue-shaped strip with a pore size of 0.2 to 0.4 micron, and with topical anesthesia, a marked filter paper strip is gently pressed with the forefinger over the sample area for 10 seconds. A glass rod or a tip of Goldman applanator can also be used for the same. The paper is then removed, and gently a reverse impression is taken onto the glass slide. Alcohol fixation done. It is placed into the Copland jar and then transported. The glass slide and the filter paper with material are then stained with hematoxylin and eosin. The cytology of conjunctival epithelial cells, including malignant cells, squamous metaplasia, keratinization, microorganisms, atypia, grades of dysplasia are all then picked up and correlated to the histopath examination findings of each lesion. With this background, now let us go back to this case with the above clinical picture. When the cytology was done and RIC was taken, a PAS or per iodic Schiff organisms was noted, and which was confirmed as rhinosporidial colonies on histopath evaluation. So this was indeed a case of conjunctival rhinosporidiosis. Now, before we understand how dysplastic cells appear on cytology, let us take a look at its normal appearance. This is a case of pseudoepitheliomatous hyperplasia, showing cells with balanced nucleocytoplasmic ratio and dot nuclei. Dysplastic cells, on the other hand, demonstrate increase in size of nucleus compared to the rest as seen above. Another key feature is the overlapping of nuclei and high nucleocytoplasmic ratio as noted in this high-powered magnified H&E stained image. So prominent nucleoli, overlapping nuclei, and high NC ratio depicts dysplasia. So how can we indeed utilize it in surface tumors? Let us take a look. This is a case of surface neoplasia with cytology where RIC was done and cytology revealed dysplasia that helped us to rule in ocular surface neoplasia. In another interesting case of squamous cell carcinoma, metaplastic squamous cells were picked up, demonstrating eosinophilic cytoplasm apart from classic features of dysplasia that we went through. In another interesting case of intraepithelial variant of sebaceous gland carcinoma, dysplastic cells demonstrating the lipid vacuoles were picked up, dysplastic sebocytes as shown here. In this case, the conjunctival lymphoma was suspected, RIC was done, that confirmed the typical Raj round cells on cytology that later again reconfirmed by histopath evaluation as marginal zone lymphoma. The limitation of performing this technique would be in certain cases, such as squamous neoplasia with significant keratin as demonstrated here, where cytology is usually negative for dysplasia. When keratin is more than 3 millimeters in thickness, it can mask the dysplasia. Similarly, in pigmented lesions such as conjunctival nevus, dysplasia can be masked again. Also, this technique is a challenge to perform in eyes with pre-existing dry eyes. Now, the original method of impression cytology involves staining and mounting the filter paper, which is difficult to perform and interpret. RIC is a simple OPD technique that can be used as an adjunct modality with anterior segment OCT to rule in ocular surface neoplasia and rule out its mimics. I would like to acknowledge Dr. Shruti, Head of Center of Ocular Pathology at Narayana Nethralaya, for the technique and the images. Thank you for your time.
So thank you, Dr. Priyanka. Hi, can you unmute yourself and quickly add on to whatever you've presented?
Yeah, at the outset, thank you, Team YOSI, for this wonderful platform. I think it's been a great learning experience for me as well, going through all the surgical videos. So, I think, given to answer Ayushi's question about how the traditional impression cytology technique is different from this, in the traditional technique, we send the cellulose paper itself for the analysis, which is first placed over the sample area. In the impression, this reverse imprint technique, what we do is after taking the sample, after mounting, after pressing the cellulose paper on the sample area, it is then imprinted onto a glass slide, and the glass slide is then sent for the analysis. So that becomes a little more easier to interpret, because in the traditional technique, when we just send the nitrocellulose paper, it has to undergo a tedious procedure of destaining, and then xylene is used to make the paper itself transparent. And also from a time duration point of view, it has to be stained and also analyzed much more quickly. Whereas when a reverse imprint is taken, you can stain it at a more convenient time. It need not be done quickly. And like I put out in the video, usually the timeline would be about 2 hours, and beyond 2 hours, because the cellulose paper itself can cause discrepancies in analyzing the dysplasia if you're suspecting any.
Thank you, Dr. Priyanka. So I'll request Dr. Maya and Dr. Akshay to quickly give their comments on this presentation. Dr. Maya? Yeah.
Yes, thank you, Dr. Priyanka. It was very insightful talk for even for all of us. And what I interpret from your explanation is that in one scenario, that is the traditional impression cytology, we are taking the imprint on the cellulose paper and then sending it to the pathologist, while in the other case, you are making the slide then and there, and then in that container, and then you are sending it, right?
Right.
Yeah, so I think that fix it then and there, instead of having the risk of distortion of the cells on the way. I guess that's an advantage. So thank you for letting us know about that. Thank you.
Thank you.
Yeah, no, I think it was a very well presented case. The whole the video. My only thing is how often do you see false negatives in this? And also, eventually we are ending up doing a excision with histopathology. So what is the true utility in this? Say, for example, when you see an orbital lymphoma, clinically you would have to eventually excise it or do an incisional biopsy to do a immunohistochemistry to subtype the lymphoma. So I can understand in epithelial lesions for sure, but could you just tell us a little bit about its role in lymphoma and cases where this has helped you in deciding or changing the management where you would otherwise go directly and excise?
Yeah, so thank you, Dr. Akshay, for that question. So the thing is, we have been using this mostly, like I said, to rule in surface neoplasias mostly and rule out the mimickers. It has had its utility mostly in these small claw-covered perilimbal lesions where, say, you would want to give the patient an option for a topical therapy. So if whether this would be a case of a squamous neoplasia and should you start them on an immunotherapeutic agent or a chemotherapeutic agent. So this, we would get the results in 24 hours, and there was an availability to call back the patient and tell them that yes, we could try this topical therapy for you, if for patients who are really not immediately willing to undergo an excisional biopsy. I agree that, of course, the endpoint is a confirmatory histopath diagnosis itself, but this has been more useful, especially in ruling in the tumors when we have dilemmas, especially the case which I showed you that ended up being a conjunctival rhinosporidiosis. So had we started them on, say, topical chemotherapy, and even the ASOCT, actually I couldn't retrieve that particular investigative modality of that patient, but even ASOCT was not really conclusive because the transition still did look abrupt, and we could have even placed a differential diagnosis of OSSN in that case as well. So those are the conditions, but otherwise I think in a dry eye situation where goblet cells and all that need to be analyzed, impression cytology still has an upper hand, because in this case, when you're doing that reverse imprint, the goblet cells can be, you wouldn't get a very accurate result in that case. And like you said, even in those cases with surface keratin, even if it is OSSN, the dysplasia is masked and pigmented lesions also.
So I think with this, thank you, Dr. Priyanka, for this, sharing this very nice video and this technique with us. And with this, we come to the end of all the presentations. I'll request the judges to, mark the Excel. Dr. Akshay has already sent it to me. So Dr. Maya, Dr. Sonam, you can just, just see the videos that you've probably missed because of technical glitches. You can send the Excel sheet to us. We'll be announcing the results over the weekend. And before we move on to the vote of thanks, we have a couple of announcements. And before that, Shruti, would you want to invite our, over to you to, take closing comments from all our judges? Yeah.
Yeah, so that was really a fantabulous and elaborate session that we had, 2 hours plus, but it was a great learning experience for all of us. We saw a lot of zest and drive among all our contestants today, and heartfelt thanks to all our judges for your valuable time, effort, energy put in today. You gave us a lot of clinical pearls and practical tips and surgical tips to follow. We could hear different opinions through different prisms from different people who have had vast experience looking at the same disease or the same surgery. So thank you so very much, Dr. Akshay, for your closing comments, please, on this.
No, I think it was a wonderfully curated program, the right kind of videos, the right duration. And maybe I think now, based on this, what we YOSI could organize is how a small program on how to take this to the next level in terms of how to edit the videos, how to get the right graphics, how to have the right kind of music overlay, what softwares to use, the narration do's and don'ts, such that these videos could then be taken to the next level and be submitted for conferences and go on and win awards, because we always have the anterior segment guys stealing our thunder.
So we do have a bio times which we are planning on some similar topic on photography and videography. So hoping we'll be able to do justice to it. Yeah. So yes.
Thank you, Dr. Akshay, for joining in. Dr. Maya,
Thank you. Thank you so much, Dr. Shruti and Dr. Nupur. And thank you to all the presenters for the wonderful, their surgical demonstrations. And I agree that the next level would be that how to improve. And I think that Dr. Akshay is the best person to take it forward. And we all are inspired by his wonderful videos and his YouTube channel. So we can always improvise. All our YO fellows can improve their presentations by looking at his videos and techniques. So thank you to all the YOSI focus group of Oculoplasty and the team YOSI for this opportunity. I had a really wonderful time during this last 1 hour. Thank you so much.
Thank you so much, Dr. Maya. And we'll be sharing the YouTube link with you so that whichever sessions you had missed, you can go through that again while evaluating while scoring. Yeah. And Dr. Sonam, your closing comments, please.
Thanks to the entire team of YOSI for such an amazing program. I didn't know what to expect when we joined in, but amazing. Like all the videos were fantastic, and it's so good to see that everyone's doing such a fantastic job. And like Dr. Akshay said, I think next we have to take it to the next level for the editing and software, and I also need to learn that. But fabulous, amazing to see this, and great going. Thank you so much for making us a part of this. Thanks a lot.
Thank you, judges. I'll request you all to stay back just for 2-3 more minutes. We have an important announcement and the vote of thanks. All the participants as well, and we'll before we wrap up, we'll have a group photograph as well. So we are joined by Yeah, so we are joined by Ayushi, and she has a very interesting activity planned from the Oculoplasty focus group. Over to you, Ayushi. You can just tell us about what you're planning next. Yeah.
Thank you so much, Dr. Nupur. I'm very happy to announce that Team YOSI Oculoplasty Focus Group is now initiating a new concept, Expressio, which is a case presentation series exclusively meant for residents and fellows on the theme of oculoplasty. I would request all faculty here to encourage their mentees to participate and submit their case abstracts. Details will be shared on social media. The aim is to enhance presentation skills and practical knowledge amongst trainees. So we really look forward to a great participation. Thank you.
And I think what Ayushi's come up with this novel concept is that that case doesn't have to be any novel or a different case. It could be just a normal case. What we would probably be looking at is how well they are presenting it, right? That is the whole point, that how well they are able to present the oculoplasty case. So I think it's a
Exactly,
fantastic
Dr.
concept.
Nupur.
And
Yes.
yes, so I think
I'm
it's
sure Ayushi is the best person for this because she's been a star fellow, and I was lucky to do my fellowship with her. I was a co-fellow. She's a very close friend, and I'm sure this will definitely, a lot of fellows and residents will definitely benefit from this.
yes, truly, Dr. Shruti. So also I would like take a chance to invite you all for our second annual conference of YOSI-Con, which is at India Habitat Center, 5th to 7th September. The abstract submissions are going on. Last date is 1st June. So please do submit and do attend. I cordially invite all the judges to come and, also attend this YOSI-Con and join us. It's going to be a 3 days of, extravaganza. Today's, webinar, what you've seen is just a glimpse, and we have so much, so much potential to tap in YOSI, and, with your insights, it's we request in fact, all the participants who are here, if you've not submitted, this is your chance to, give faculty submissions or whatever you want to submit. It's all there. So please do register for YOSI-Con. And with this, we come to the vote of thanks. At the outset, I would like to thank the team YOSI Governing Council for giving us the opportunity, the YOSI Oculoplasty Focus Group for, putting up this program, and the co-moderator, Dr. Shruti, for being the fantastic teammate and helping seamlessly conduct this program. To all the participants for your wonderful efforts and enthusiastic entries. This would not have been successful if you would not have submitted, and it was such a pleasure to watch all the videos. To our judges, 2 hours plus, the three of you were there with your heart and soul, discussing with the same enthusiasm in the first and the last video. That's commendable, and your pearls of wisdom and insights were just amazing. Thank you so much, Dr. Maya, Dr. Akshay, and Dr. Sonam, for your participation. So we have this email ID. If you have any feedback or any activity that you think can be planned further, please do write to us. And also a huge thank you to all the audience, who are watching. And with this, we call this a wrap. Thank you to Numerotech Manjula for, helping us, giving the technical support always for all the webinars. Thank you so much. So Manjula, you can just stop the live, stream, and we can have a quick group photograph. I'll also try to join in through my phone so that I don't miss out on the photograph.